Good morning, Barry. Ladies and gentlemen, thank you so much for including me in this wonderful meeting. I'm just going to share my screen. This part of the program has been sponsored by CAT Medical. I'm going to tell you a different story, but I first want to actually introduce you to Professor Eric Topol, who is the Chair of Translational Science at Scripps in San Diego. He wrote these two books. His last book is called Deep Medicine: How Artificial Intelligence Can Make Healthcare Human Again. He recently tweeted that we still use dumb algorithms in medicine developed decades ago, eagerly await validated smart ones, #AI. AI is seen as some kind of magic bullet, but can it truly transform healthcare? The answer is no in the short term, and possible and even likely in the long term. If we think about healthcare today, we have a person living their life happily, and then lightning strikes and they develop signs and symptoms of disease. And we as physicians then start ordering a battery of investigations to formulate a treatment plan. But in cardiovascular medicine, it may be too late because the first event might have been a devastating stroke, MI, or even death. It is obvious that the underlying pathophysiological abnormalities that have led to this have been developing over years. Just look at this vulnerable plaque in the LAD. It ruptures, causing a massive anterior MI, and sometimes with consequent ventricular tachycardia and fibrillation. So if we had some way of detecting this early on, we might have been able to predict and prevent a sudden catastrophic event. We surely can do better than just merely waiting for signs and symptoms to develop. We've been doing this for many, many years. This is Professor Paul Friedman. He quite rightly calls AI the next frontier. If you look at the two echocardiograms at the bottom, they're four-chamber views. This is a patient with normal left ventricular function, on the left with left ventricular dysfunction or a dilated cardiomyopathy, So Professor Friedman and his team used an AI-enabled ECG to screen for asymptomatic left ventricular dysfunction, which occurs in 2% of the global population and 9% of the elderly. What is important is that if you knew that you had a weak heart, there are treatments, ACE inhibitors, beta blockers, spironolactone, ICDs, biventricular pacemakers that all reduce mortality and recurrent heart failure hospitalization. The key point is that you have to first know that the condition is actually there. With all this in mind, if you place a microelectrode into a single cardiac myocyte, you get a characteristic action potential, which is due to the synchronized orchestra of millions of electrical channels, the function of which was so important that they govern all of your bodily functions and even the thoughts that you're having right now. The arrangements of these will affect electrical signals of the heart, and perhaps AI could detect these earlier on in the disease process. And if we record the summation of millions of these channels at a distance from the heart, we get a ubiquitous, inexpensive test, the electrocardiogram. And we can glean a lot of information from the ECG, but not even skilled clinicians can look at an ECG and say for certainty that a low ejection fraction is present. The team used a convolutional network and trained the network by feeding in paired ECG and echocardiogram reports. It processes the information, and the first time it's going to take a guess. But through a process called backpropagation, it then balances the weights and biases of these mathematical neurons. And just like as a child learns that a ball is round and it bounces, so does the AI learns to learn over time that a particular ECG is associated with a reduced ejection fraction. And to test how well the network did, they then presented it with 53,000 ECGs and echocardiogram pairs. And performance was measured by the area under the receiver operating curve. A perfect score would be 1. And if we think about commonly used tests in medicine, for mammograms it is 0.85, stress ECG is 0.85, and pap smear is 0.7. So this was a very powerful test, as the AUC was 0.93 for the computer's ability to read the ECG and to say that there's left ventricular dysfunction. But what is more important and interesting, the long-term outcome of patients with a false positive AI ECG. The AI said weak heart, the echocardiogram was normal. If these patients were followed for 6 years, they had a five-fold subsequent increased chance of subsequently developing a dilated cardiomyopathy. What is really happening is an early pathological process affecting electrical currents that you and I can't detect when we read an ECG. It seems to be able to predict disease before it becomes clinically manifest. And this is important for high-risk patients, perhaps receiving cardiotoxic chemotherapy agents. If flagged by the AI, they could be followed up more closely with further imaging. And it raises this concept of AI disease provider. What would you do if you knew that you are going to get a disease? How would you prevent it? What are the insurance, legal, and financial implications? And there are many such questions as more algorithms are tested and validated. In May of 2020, the FDA gave this team emergency authorization for its use to detect LV dysfunction in COVID-19 patients. And they've licensed one form in a stethoscope, but there are multiple other forms, such as in smartphones, making this massively scalable. So how will this integrate into the workflow of primary care practice? Can practice be changed? All of the testing that I've described have been in silico and retrospective. We're talking about databases and what-if scenarios. The ultimate goal is that a patient presents, has an ECG, the AI analyzes it, it issues a notification, an echocardiogram then confirms the diagnosis, and then this drives the initiation of guideline-directed treatments for left ventricular dysfunction. Well, in this prospective randomized clinical trial using the same AI ECG, it was used to screen patients without a history of heart failure in primary care practices in Wisconsin and Minnesota. The primary outcome was a new diagnosis of a low EF, and it increased the diagnosis thereof by a third in the overall cohort. What is interesting is that the accuracy was identical to that in the retrospective paper that I alluded to just now. The overall image utilization was similar across both groups, but more echocardiograms were performed in the intervention group in those patients with a positive AI ECG. It led to better selection of who should receive an echocardiogram or not. So it potentially may improve the early diagnosis and treatment of a condition that is often asymptomatic, but has effective treatments. So just changing direction here, this at the bottom is atrial fibrillation, this animation, the commonest arrhythmia that we see in clinical practice, and it's obvious to this audience that it is the leading cause of stroke worldwide. A third of strokes are cryptogenic, but may well be due to atrial fibrillation because of its paroxysmal nature. Obviously, when AF is found, anticoagulation significantly reduces the risk of recurrent embolic events, but empiric anticoagulation provides no benefit and may even cause harm. Short-term ECG or Holter monitoring underdetects it, but AF is found in 30% at 3 years with prolonged monitoring, such as with an implantable loop recorder, but it leaves a substantial number unprotected from recurrent AF during that period. It is well known that structural changes occur in the heart before the arrhythmia develops. Could these be detected beforehand, before the consequent embolic complications? Well, AI may now detect future hidden AF when patients are in normal sinus rhythm. This, in this Mayo Clinic study, a similar AI ECG performed well and could predict future AF, and they trained the system on 650,000 ECGs from more than 180,000 patients. The AI never saw the AF, but it was fed the ECGs of the preceding sinus rhythm. It was told that these patients subsequently developed AF. The AUC was 0.87 for a single ECG in sinus rhythm, and 0.9 for those with multiple ECGs and sinus rhythm. And this really compares well with other screening tests such as BNP for heart failure, and then the CHADS-VASc score. Barry, would you agree that the CHADS-VASc score is almost like a thumbs up, coin toss? So the data indicates that a simple, inexpensive, non-invasive test may permit identification of patients with under-detected AF. It could identify high-risk patients of cryptogenic stroke who might benefit from empiric anticoagulation, and this will be the subject of a large future randomized trial. The team is presently recruiting 1,000 patients into the BEAGLE study. These are patients who do not have a previous diagnosis of AF or flutter and would be eligible for anticoagulation if AF is detected. I had the opportunity to interview Professor Paul Friedman at last year's SAR Pro conference. He was the closing keynote speaker. And we are going to collaborate with Mayo, particularly in the areas of valvular heart disease and peripartum cardiomyopathy. Ladies and gentlemen, this is Sir William Osler, the father of clinical medicine. And more than 100 years ago, he said that medicine is a science of uncertainty and an art of probability. And perhaps all these breakthroughs and innovations will render this highly relevant quote redundant in the coming ages. I thank you for listening to my crazy talk.
Oh, Dave, thank you very much. It certainly wasn't a crazy talk. I mean, the cardiologists probably are going to be the least likely affected by AI, because you'll still be able to do, your work can't be taken over by a machine. Just two quick, I think I agree, the CHADS-VASc too, has sort of stood the test of time, but there's a better algorithm brought out, a computer generated algorithm that under the guidance of Lord AJ, who's one of our panelists today, that we developed under the Garfield AF study. So there are definitely computer techniques will improve our ability to predict disease. But the question that I wanted to ask you, but you may be the wrong person to answer, is as a cardiologist, will radiologists, other than invasive radiologists, become redundant? And maybe hematopathologists, if it's purely pattern recognition, will the computers not be able to, dermatologists, will computers not be able to be better at predicting patterns than we as clinicians?
No, I don't think that there's any data to suggest that clinicians are going to be replaced, even in the most vulnerable specialties. And it has been said that AI won't replace radiologists, but radiologists who use AI will replace those who don't. So I think it's man and machine, it's a combination. And it also has been predicted that no imaging study will be looked at by a radiologist until it has been pre-screened by a machine. The whole aim of technology is to free you up from repetitive tasks so that you can get back to the business of what you really need to do. So I think in all your specialties that it's going to flag what you need to look at more closely and free you up.
Harry, could I come in? Yes, I would just make one observation. I thought that was an excellent presentation. And of course, the power of AI and of all the other tools we're going to have available to us in clinical practice is it will allow us as clinicians to return to the one thing that has started to be absent in routine clinical practice, and that is our capacity to spend more time with our patients rather than less times with our computer screens, and focus much more on compassionate care, which is the key critical element of being a good doctor.
Professor Kakar, that's a good point. And what I want to actually say is that the greatest benefit or opportunity for technology in medicine is to restore the time-honored bond between doctors and patients, so that we can just get back to doing what we're supposed to be doing, caring for patients. Thank you.